Hello and welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. And today I'm super excited to be joined by Dr. Sister Priscilla and Sister Gertrude, who have traveled all the way from Uganda and are visiting us in the States for a few weeks. And so I am not going to try to introduce them. I'm going to ask them a few questions so we can get to know them better. But welcome so much. How are you all doing today?
Oh, thank you very much, Mary. Glad to be here and also to speak with you. Just doing very fine, and we are looking forward for this opportunity to share with you.
Yes, yes, I'm so excited to learn more about what you all are doing. So, just to kind of get started, why don't we just let's get some background. Tell us what took you into the sisterhood and what took you into medicine. So, why don't we start with Sister Gertrude, and then we'll do move on to Dr. Sister Priscilla, if that's okay.
Oh, thank you, Mary. First, we both belong to a religious institute called the Daughters of St. Teresa of the Child Jesus, locally known as the Banyatereza Sisters, founded in Port Portal, Uganda. I joined sisterhood way back in 1988, and as a child, of course, I first admired the nuns, the way they were praying, but later on, I felt I should maybe serve God, mostly to help the people whom I saw the sisters helping, especially the poor. Yes.
I like it. I like it. And you, Dr. Sister Priscilla?
Yeah. So my story is a bit different. I joined. I was born in a village. My mother never attended an antenatal clinic, and I survived being a fresh stillbirth, a woman delivering by herself. And then I went to school in my village, and after elementary school, I just fell in love with God. I wanted to be a sister because I knew sisters also were set aside to help the poor. And then after elementary school, I joined a secondary school or high school. And then after that, I became a sister. I became a sister after elementary school, then started school again. Of course, there were a number of times I dropped out of school. And then after I had become a sister in school, then finally I went and did physician assistant. And then later on, I made my way to become a general practitioner. And then after meeting several challenges, I went for residency program and became an obstetrician and gynecologist. Just that cut the story short. Yeah.
And so, and thinking about, so, we're kindred spirits because we like the maternal health pathway. Can you tell us a little bit about the kind of state of maternal health in Uganda? What are the specific issues that are facing the women there?
So in Uganda, what we should say, what we are battling with is still our maternal death, which is still way high up, where you have, if every day we consider 14 to 16 women dying in childbirth and with pregnancy and its complications. And the major thing that is at the top of the things is the hemorrhage mostly, and then obstructed labor. And then when obstructed labor leads so many women to several complications like fistulas and birth injury of all categories. So women tend to live with these injuries for a long time. Of course, their quality of life becomes different, especially these who develop like the obstructed labor, and then they have fistula. They have perineal tears, they can't control their bowels. So all this time they become like social outcasts in the community. So where now most of us as obstetrician gynecologists, we're trying to make sure we raise awareness so that such a women can be helped within their community. And as a nation, there are several programs going on, but also where we work as sisters, it's a mission hospital. private not-for-profit, where we try to go in hard-to-reach areas, especially to alleviate the suffering of such women. Even those who have the opportunity to reach the health care, they don't have the money to pay even for a simple cesarean section. Yeah, so we are trying to do several things in the community, especially developing a center where women can have a walkable distance within their situation and have a very safe C-section so that they can have a live mother and also go home alive.
Indeed.
Yeah.
And Sister Gertrude, can you tell us a little bit more about the history of the clinic there and how that evolved and how you all created the space to be able to provide more care in the community?
Okay, this clinic is situated in a rural area. It was started by the Banyatereza Sisters on our own piece of land, which is about 260 acres. And out of that is carved out 72 acres for the facility. So the sisters founded it and started treating people on a veranda because people came, requested sisters for treatment. They know we have nurses, but in the community around, there was no clinic at that time. That is in 1995. The nearest clinic by that time was 28 kilometers away. So sisters would clap patients under a tree, then have them admitted on a veranda with the drip hanged in the window. So from there, as the number of patients increased, more sisters were added. So the sisters decided also to put on a temporary shelter where they could admit at least more patients or serve more patients. And in 2006, sisters decided to expand so that the patients can have a better place where they would get their treatment from and also closer to the road rather than walking 2 kilometers away seeking for healthcare. So out of the stipends that we were all getting, $30 monthly stipend, so we all decided to share 30% of that. So we put all that money together, put up an outpatient department, which is serving even now as multipurpose for clerking rooms, offices, and admissions. And some of the admissions are in the hallway. In 2017, we made partnership with African Mission Healthcare that really has helped us to put up some of the other structures that we have right now. At least we have a theater, surgical theater, where we do C-sections. We have the children's ward, but we have doctor's house and the sisters' convent. So, but the other services stay in that building that is multi-purpose. Yes, yes. And also, African Mission Healthcare has supported us to train healthcare workers who are also working in that health facility plus other health facilities, but also mostly focusing on nuns who are going to be stable in that place, not like moving away to go look for greener pastures, but they serve the community, the poor that are in the area.
Wonderful. It's so exciting. So, a lot of times we talk here, so our maternal mortality rate is not the greatest. Now it's not as poor as it is in Uganda, and we talk about social determinants of health, and one of those we talk about is transportation, right? And I say the social determinants of health, they're the same everywhere, but how they manifest is different, right? And so here, when we talk about lack of access to transportation, we talk about, well, maybe you don't have a car, or maybe you can't use a bus, right? And so I was able to volunteer in Kenya for 6 months, right outside of Nairobi and Mutomo. So we were in a very rural setting. And so when I was telling people, I sent our ladies home on pickies or on motorbikes after delivery with the newborn. They were like, "You do what?" And I was like, "Yeah." So when we
maybe one thing I didn't say, the expansion of that clinic resulted from Dr. Priscilla's findings from the clinic, from the hospital where she was serving. Maybe she can give a highlight on that.
I was in a hospital, it's still in the same region, but a little bit like 1 hour and a half drive. And every time I'm on duty, I would see these very obstructed labors, difficult deliveries. And then we took time to say, where are they coming from? And then we realized there was a particular place in the region where they were coming. And then we took an outreach and visited to find out the circumstances. And that's where we found that this is even a place closer to where we have land as sisters. And in an effort to say, well, how can we help the community? We said, as sisters, what charity can we do? Since this is our own land, we have it as our own, we can build something there. No one will just say, take it away, but for the community. But what we needed was the support to build it to a better center, to a maternal center. So now that's the blessing that we had. So it was from that assessment that we started building up that center. And when you talk of borders, I remember a story. One day a mother came to me in the hospital and she was in labor. She had labored for 48 hours. And then she landed on a pikipiki, a border, and then this bike, and they fell down. Thank God she didn't get a ruptured uterus, but she got a huge tear on her upper lip. So she was bleeding, she was obstructed. And after arriving, I'm like, so what thing do I start with? So immediately the thing was, start with the baby. After the baby, then take care of this other surgical repair of the upper lip. So I know what you talk about. That's our daily bread. We meet all these ladies like that. Yeah.
Yeah, it's so dangerous, right? Says you have the danger of the obstructive labor, but also of the transportation. So it looks very different. And just for our listeners, so we've said a few words I probably should define. So obstructive labor is when you're in labor for a long time. So and it's not progressing. So you can be in labor for a long time as long as it's moving along. But when women are in labor for a long time, that can lead to damage to the pelvic floor. And we mentioned fistulas earlier. So fistulas are communications between two body parts that aren't supposed to be communicating, which is often the vagina and the rectum, or it could be the vagina and the bladder. But those have to be repaired, of course, if they happen. And so obstructive labor is one of the things that can lead to that complication. And we mentioned earlier, if those can cause leakage of things uncontrollably that we don't want to leak, like urine and stool. And so that can be very, of course, dehumanizing to the woman who is experiencing it. But also, you talked about being ostracized or not excommunicated, that's a strong word, but from the community because they have trouble controlling those things. So just so people know some of the vocabulary that we're using when we talk.
That's very true. And I think it's really, as you put it, no one can have the strongest word to talk about those women, because the ability of someone not becoming a social being, you can't go to any gathering to pray with people, to fellowship with them, or even to the market to buy things. Wherever you pass, people are smelling urine, smelling feces. So the woman tends to be completely out of society. And some of them, it causes a lot of depression. Others feel they are cursed. And yet it's something simple. If they had assistance, they can be repaired and it's all done. Whenever we have surgical camps, we use the term birth injuries because previously we would say fistula, and we realize those who are leaking urine are becoming less, which is very good. But also there are those who have had like the 4th degree tear, all the connections are together, and not controlling gas and bowel is equally very bad. So that's why we use the term birth injuries. So we started conducting those camps that African Mission Healthcare has been helping us to fund each woman to come and have that. And then we also have a program on social integration, because once we repair them, we don't stop on that. We need to take them back to the community so that they can regain their dignity in the community, because many people tend to see them as like outcasts. So now, after repair, we don't want them to live the same way. We've restored their dignity, their human body. Now we take them again to the family, talk with the family, make sure they fit in well. So it's a big thing altogether that we do for those women. Yeah.
And that's an important part to bring that back up. I'll tell this one little story and then we'll go back to something else. But when I was in Kenya, I met a woman, and she had a 4th degree that hadn't been repaired, and she didn't come until her husband died. So she had been walking around like that for 30 years.
Yeah, exactly.
And then he died, and she came, and she was so excited, and we were able to refer her out so she could have her surgery. But it's just, to your point, people have just withdrawn from society for so long, and they need that help integrating back in.
Yeah, that's true.
So I'm glad that you keep it carry on. It doesn't just end with the surgery. So that's so exciting.
That's true. Yeah.
Sister Gertrude, you did mention the part of what you all do is not just provide healthcare, but also train other healthcare providers. And so tell us a little bit more about how that started and how many people you've trained. And is it nurses? Is it clinical officers? Do people, go on and go to medical school and become physicians? Like, what's the composition?
Okay. The training program we have is diverse, I can say. So we train ranging from nurses to medical officers, and we say healthcare workers. Currently, we have 92 in a number. That includes those who have completed and those who are in school. So 52 have completed their training and 40 are in school. But the majority of those are nuns from 4 religious orders, and these 4 religious orders serve in the 4 health facilities that are supported by African Mission Healthcare, and also in other lower level health facilities where that are founded by these sisters, where the sisters serve, because the referrals going to these mission hospitals mostly come from these lower level health facilities. Also, among the 92, we have other lay brothers and lay sisters whom we have also trained, who also are bonded and come and work in these health facilities. So before this training started, we had challenges of management. For lower level health centers are managed by nurses who have diplomas, or nurses with on diploma level, or clinical officers. So, but we would improvise, have like a nurse on a certificate level or enrolled head these facilities, which was not really right. And also we had many nursing assistants working in these health facilities. But with this training, the impact I can say is that we have an increased number of qualified staff in these health facilities. Also, we have an improved retention of these staff in these health facilities, which in turn also improves the quality of care to the people in the community. So people come get better treatment rather than being referred most of the time because a qualified staff is not on site.
Exactly. Yeah. And that was my experience too, because you all there still have the and they called in Kenya, it was like level 1, 2, 3, 4, right? So it's different levels of health centers. And so if you're really rural and really far and remote, then you might, like you said, just have one nurse there, a clinical officer. And then at the bigger hospitals, then you'll have the full complement of staff. It's kind of set up the same way.
And you see, Mary, the good thing with this training is that we are not only training for us for this clinic, but for the whole region, so that we can be a center where they will come and learn, but they go and do good things in their own hospitals. And another thing is that we don't focus much on, we are training only Catholics, but we train also people with a good heart, those who want to serve, those who have, humanity in their heart. So, yeah.
Yeah, maybe giving a little more on numbers, training a doctor with experience from the time we started. In Uganda, it costs around $25,000. Then the clinical officer goes for $15,000, a nurse $4,000 on diploma level, certificate $3,000, and just for the entire course of training in those cadres. Yes, and also our sister has talked about the birth injuries. We also AMH also supports us for C-sections for mothers who cannot afford, and the C-section goes for $250, and the birth injury for one mother $500. So that has with the theater we have at that center has helped many women have C-section, those who could not really afford it before we got the theater, and also it has saved mothers from being referred when they cannot afford transport, and also getting accidents, as she said, on borders in these motorcycles. Yeah.
And so, and for our listeners, we will give you information. So there is a way that you can support, especially moms who are, as Sister Gertrude just said, may come in and need a C-section, not have the money to afford that. So we'll give you information at the end on how to figure out how to support that cause, if you will. And then any others like stories that you're excited about, or success stories that you've witnessed over the past few years that you'd like to share?
Oh, those are so many. But I think the key stories is about how women appreciate this service, how women sometimes see you and meet and say, oh, you saved my life. I've seen those who have repaired from birth injury coming back to the facility for their antenatal, and also delivering babies when they had lost hope completely. I've seen mothers who have come again all the time, like they have been repaired 2-3 times, and sometimes it doesn't work, but we try again for them and it works. But I think most exciting story for me as an obstetrician and someone who wants others to learn a skill is the mentorships and that we do. So we in all these facilities in the region, we try to conduct what we call it clinical audit. So once we pay mothers, AMH pays for a mother for C-section, we want to go into these facilities and find out, was this C-section done for the right intention? Was it a right indication, or it was about money? So once we find the indication, we want to say, how long did this mother wait? On the third delay, we want to solve that so that when the mothers arrive, there's quick response and an intervention. Also, we try to find out in this clinical audit, what was the outcome, the APGA scores, because they mean a lot for these babies now and even in the future for their school and for their education. And then we see at the discharge, we look for the reports. Are they discharged with the right information? Can any other clinician follow up and know how many hours this mother spent in labor? So all that, we do it in our clinical audit. And what we do, we sit with the doctors in that hospital or in that clinic, and we go together through the chart and the notes and find where there are gaps so that they can fill in the gaps. And we think that's the best training that we can offer, because themselves identify where there are issues and then they are able to correct the issues. So, and right now we are also trying to say, in our facility, once we build the birthing center, we want to have a simulation, a room, at least people can come in the region. In that region, I don't think if there are any simulation centers, there are like maybe 2 in Uganda, and the rural can never ever access them. And I am sure, I'm thinking now, the thinking is more of people, if they can do simulation, much as we have patients, but sometimes for really better learning, it's also good that we can add that as an added benefit to our training programs.
Indeed.
Yes.
And thinking a little bit more broadly, so you talked about some of the policies and procedures locally,
Yeah.
and then expanding to training in the regional level. Is there
Mhm.
anything on a systemic, like countrywide infrastructure level that you wish was different or that you think could influence maternal health on a broader scale?
I think on the as a nation, the funding to maternal health is always actually, for healthcare, the budgets are always so low, and yet there are many things that come in. For example, if I talk now, right now, as we discuss, we know there is an outbreak of Ebola that has come. So you'll find that all now funding is shifted to that. And in that scenario, the mothers who are pregnant, the pregnancy is not shifting or stopping. So at the end of it, they end up in bigger problems on behalf of other things that have happened. So when COVID came, it was terrible. Again, the lockdowns, mothers couldn't attend the clinics, the antenatal, even those who can walk to the facilities couldn't. And then they delivered at home, then problems worsened. So I think the funding is the big thing for the country, but a difference can be made if we do our part in those small clinics where we are, in the rural, in the hard to reach, so that we can just be a small light in the darkness. Yeah.
I know we don't have much more time, but I do want to give you a little time to talk about this amazing award that you received recently. So will you tell people about the award and the significance of it? Because you are first among first. So I'll let you tell them.
Thank you, Mary. So the award was so humbling that being a first African religious sister to receive this, this was the L'Chaim Award that is given to a missionary who has had exemplary kind of service to humanity, and it's awarded every year. So I was announced the winner 2020 during the COVID time, although I couldn't come, but this time I was very happy that I was able to be here and at least put a face on the members. But what it has done, the primary aim is to build a center of excellence for maternal health and child health in the community, in that place which is hard to reach. And so, and we want to put a component that is not common, especially the compassionate care, the respect of a woman. Because if we treat women with respect and dignity, saving one woman means the whole family, the whole village. Because once we lose one mother, the other 4 are left orphans, and the family is disrupted. So we are aiming at building that. And also the L'Chaim Prize, that award has helped us to have water. We didn't have running water in the facility. So we had a big borehole. We built a tank of 40,000 liters, and we are able to supply water in the whole hospital and in the school near. And also there's an outlet for the community. And right now we are trying hard to make sure we can have doctors' residence and also those who will work in the birthing center. Yeah.
That's amazing. So congratulations. It's so
Thank
amazing.
you. Thank you. Thank you.
And then Sister Gertrude, before we go, tell us a little bit about what you're raising funds for now, and then we'll tell them where they can go to get some more information.
Okay. There are many things that we are raising funds for, but right now, the very crucial ones is these C-sections, birth injury camps. Also, we need to stabilize power. at that birthing center that we want to build. We don't have wards, surgical wards, general wards in place. So also we had a laboratory and the pharmacy that are part of OPD structure that is required, but right now are in that multi-purpose building. So, but it's vast. There's so many that are needed, but those I think are the crucial ones. Also, there is this program, Universal Health Coverage, that's also part of a beneficiary of the L'Chaim Prize. And this is a health coverage for members totaling 9,700 by now. And this is supported through MH by capitation model, whereby a donor pays less than $1. And this is actually, to be exact, like 52 cents per enrolled member. And also when someone falls sick among the enrolled members, they make a co-payment per visit of like $3 because average treatment for an outpatient is around $25. So for the whole year, this goes for like $60,000 for the 9,700 enrolled members. And this program has really supported the people who cannot afford healthcare. Before it started, we used to see mothers bring more than one child very sick to hospital. So when the program started, we did some kind of assessment research in the community. We found some mothers would take children to clinics and get one dose. For example, if the children had malaria, get a dose for one child, but share it among like 4. So that would make them like more sick in the long run, and they would all come to the facility. But since that time, since we started the Universal Health project in 2017, we have not seen that scenario.
Amazing. You all are doing wonderful, wonderful work. I'm so excited that you were able to share with us today. Anything you want to leave people with before we go? Anything that you're hopeful for, optimistic about, looking forward to, either for the rest of your trip here or when you go back home?
I want to say, I want to leave something with the people that about the quickest publications that people make in life. And those are the publications I keep talking about. As an obstetrician, I just felt like it's not about only writing, but also once we make a difference in each person's life, it's a big publication. And in all honesty, every time we do birth injury camps and a woman, I put a smile on a woman's face, I just feel that is the fulfillment that I can have. If I can sacrifice something small for these women to give them a better life, I feel that is something. And maybe the thing is that all of us to know that we came from somewhere and we are going from somewhere, and all we need is to leave a legacy, and also just to say we do our part, and we know just that God loves us. Thank you.
Yeah. What about you, Sister Gertrude?
Yeah, I just want to thank you so much, and also to say the support that we give one another reflects God's kingdom among his people. Thank you.
And I can't add anything better than that. I am not gonna try.
Thank you, Mary.
But everyone can find more information at africanmissionhealthcare.org, right? Did I get it right?
Yes.
And I'll put it in our listening notes too, so you can learn more about the sisters, more about the clinic, more about how to contribute and donate to the wonderful work that they are doing there. Again, thank you, ladies, so much for joining us today. It was really great to learn a little bit more about you and everything that you're doing in Uganda. So with that, thank you, and I bid you well on your journey back home.
Thank you. Thank you very much, Mary. God bless you, and thanks to all our viewers. We are grateful.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.